Welcome back. We're continuing with our Green Mountain Care Board overview, and we're joined by General Counsel Michael Barber. So thank you for coming in today.
Thank you for having me. Again, Michael Barber, General Counsel for the board. I'm here today to talk to you about our rate review program. We use the term rate a lot in our work, but when we're talking about rate review, we're talking about the program by which the board reviews premiums, which we call rates for health insurance plans. And Chair Foster talked about what plans we review. It's fully insured major medical health insurance plans, sometimes called comprehensive coverage. These plans are they're offered by private insurers in one of three markets: the individual market, small group market, and the large group market. Individual plans are available to individuals who want to insure themselves or their families. Small group plans are for employers with 100 or fewer employees, and large group plans are for employers with more than 100 employees. That dividing line between large group and small group is a little bit different in Vermont and in some other states where it's 50 employees. So we decided as a state to define our large groups as 100 or more than 100, sorry. So just a brief minute to talk about what plans that does not include. So we're not talking about self-insured employer plans, Medicare Advantage plans, Medicare supplemental plans, obviously not traditional Medicare, not Medicaid, and not any of the other myriad types of plans that might cover medical care. So not limited benefit, long-term care, specific disease, student plans, workers' compensation plans, any of that stuff. In terms of statistics, last year, the board reviewed 10 rate filings, representing approximately $810 million in premiums for approximately 82,000 people, over 70,000 of whom were in the individual and small group markets. So that gives you a sense of just how small that large group market is here in Vermont. The insurers asked for about $150 million in increase, and the board reduced those proposed increases by an estimated $11.4 million. Chair Foster spoke to the solvency issues that Blue Cross Blue Shield is experiencing and was experiencing at the time. That significantly impacted the board's consideration with respect to its filings. No one's not here anymore, but this last point is something I stole from the JFO presentation, which I think comes from the Household Health Insurance Survey, but roughly half of Vermonters have private health insurance, and the overwhelming majority of those people with private insurance are covered by self-insured employer plans, which again are not subject to our rate review process and by and large are not subject to state regulation.
Just to level set for the committee, essentially what we have, that piece of the pie that Nolan's always showing us is virtually the same, other than we have some over Medicaid, but same as Green Mountain Care Board.
The rate review process was tried to capture it on this slide. It starts with a insurer filing its proposed rates. Those proposed rates are supported by an actuarial analysis that describes how they developed them, all the assumptions and underlying data that goes into that. We at the board don't employ any actuaries, but we contract with a actuarial consulting firm to help us review the rates. So once we get a filing in, they will start reviewing it. They'll start asking the insurer questions. The board will start asking questions because the actuaries only look at part of our rate review standard. The healthcare advocate suggests questions, and those will get asked either by our actuaries or by the board. by the 60th day of our review, our actuaries provide a report that describes the analysis that they've done, opines about the rates and makes recommendations for modifications to the rate if they have any. Department of Financial Regulation, which is in charge of insurer solvency in Vermont, submits an opinion about the impact of the proposed rates on the insurer's solvency. After those kind of two key documents come in, we hold an evidentiary hearing. Typically, that's just for individual and small group plans. The large group plans typically don't have a hearing. After those hearings are held, for the individual and small group plans, we actually hold a special public comment meeting or hearing, so people can come in and talk to the board about their concerns. Throughout the process, we have an open public comment period so people can submit written comments to the board or call us and we'll help them work through any comments they have. So that period closes after the evidentiary hearings are held. And then the parties file briefs or memoranda. The board deliberates, makes a decision, issues a written opinion. That has to be done within 90 days from the date of the filing. And then those decisions can be appealed by either the healthcare advocate or the insurer to the Vermont Supreme Court. So this slide is just to give you a sense of what goes into it, what the components are that make up a rate. And I apologize if that text down there at the bottom is illegible. This is an image of a slide from another presentation. It says that around 85 to 92% of the premium is the result of claims costs. So that top vertical gray box on your left, most of the premium is going to cover projected claims costs. The non-claims component is things like administrative expenses, taxes and fees, contribution to reserve or margin, which Chair Foster spoke about needing to maintain or build up those reserves to be able to be there and continue to pay claims. On the claims side, it's broken into medical claims and pharmacy claims. And within both of those categories, then you're talking about the utilization. So how frequently are people utilizing drugs or services, and the unit costs. So what is the change in price for those drugs or services? And then from there, you get into specific types of care. Won't go into that unless you have questions, but this is just to give you a sense of all the different components in the rate. And then my last slide is just to also give you a sense of what other agencies and steps are involved in bringing a plan to people. So these are different regulatory steps. The ones with an asterisk are specifically for the individual and small group plans, which are highly regulated by both the state and the federal government. So there's a plan design process, which the Department of Vermont Health Access runs, where they look at changing the cost sharing parameters of a plan. So changing the deductible, changing the maximum out of pocket, copays and things like that. DEVA then recommends those plan changes to the board. The board issues an opinion about that, approving them typically. Then policy forms are filed with the Department of Financial Regulation. So they're doing their form review kind of as we're doing our rate review. Again, Department of Financial Regulation is involved in the rate review through its authority over solvency. After the board approves rates for the individual and small group plan specifically, there's a plan certification process that DIVA does. And then once the plans are certified, there's a lot of work I don't have any insight into that DIVA does to load the plans on the exchange, test the subsidy calculations, get all the language on their website right, and kind of be ready for that open enrollment, which begins at the beginning of November. And that's all I had, unless you have questions.
Any questions at all? Leslie? Question. Sorry, I'm chewing. Is there any thoughts or recommendations of changing this? Or you think it works and you're good with it?
No, we don't have any recommended changes to the process. No.
I actually had one question just for my own knowledge, and for the life of me, I cannot remember. Oh, medical loss ratio, that's it. In the rate review process, you had, the administrative and the claims buckets. Does the amount to go into reserve, does that go towards the medical loss ratio? I mean, there, as a qualified health plan, they have to remain underneath a certain threshold for administrative costs. Is that included in it?
Right, that, so I think it's 80% medical loss ratio for the individual and small group plans and 85 for large group is the requirement. That is a good question and I don't know the answer right off the top of my head.
And maybe you can explain if you know what medical loss ratio is.
Yeah, no, high level medical loss ratio is how much of every dollar you take in going to pay for claims versus something else. So it has to be, you have to have a minimum amount of the premium going to pay claims.
And that's a CMS requirement or a requirement under the Affordable Care Act.
It is, and it's also a requirement under state law.
Okay. All right. Oh,
Just thinking while you're going over some of these things, the ability to sue our insurance or to sue physicians that may be insured, does that go into your rate costs for your rates? And is that something that perhaps this committee should be looking at, limiting the amount that somebody can bring suit, say, against a physician or a hospital or whatever? Is that, this probably goes back to Chair Foster, but does that have an effect upon the high cost of our insurances here in Vermont?
Good question. I don't know that I have a great answer for you. I don't, if it is not an explicit factor that I'm aware of, but I'm sure medical malpractice coverage and things like that affect the price at which providers can deliver care. So it would show up in the prices that they charge that way. So in that sense, yes, I think it does play a role. What size of role, I don't know.
But I don't know what role it plays in Vermont, whether it's a big issue as it might be, nationally in other states.
I don't either. Sorry.
I have a little bit of place to defend the malpractice cases. Anecdotally and generally speaking, Vermont's not the most litigious state in medical malpractice by a wide margin. The awards are relatively conservative. To give you a sense, it's public. I defended a medical malpractice case against KHC. Net Monticelli died from alleged medical malpractice. The case settled for $499,000. So when Ms. Byers, she died from alleged medical malpractice. Her settlement was $1.5 million. So not kind of the runaway malpractice things you would see. They're relatively rare compared to other states.
Were those actually litigated or was that a settlement?
I settled those. But they were very sharp plaintiff's lawyers on the other side.
Oh, okay. Because they don't, the hospitals don't typically
Sometimes, yeah, sometimes we win, sometimes we don't, and there's probably a lot of malpractice that people don't sue for as well. I mean, the majority of all litigations, like malpractice with us, but yeah, the hospitals will find appropriate circumstances.
All right, so I think we're gonna move on to certificate of need. And I think I just wanted to flag for the committee, in case you haven't had a chance to look at bills on our walls. We actually do have a bill on our wall revolving around certificate of need, and I believe in the Senate also has a couple of bills around certificate of need, so we should know what it is. Yeah.
Hey, good morning. Good morning. For the record, my name is Laura Beliveau. I'm a staff attorney at the Green Mountain Care Board. I work on a certificate of need, but because we're small but mighty, I also work on rate review and public records issues. So, and not slide control here. At a foundational level, certificate of need is Care Board that authorizes the holder to proceed with a healthcare project. The rationale behind it is found in our statute. The goal is to reduce duplication, redundancy of services, contain cost increases, and improve quality and access. Vermont is not unique in having a CON program. About 35 states and the District of Columbia have them. In New England, all the states but New Hampshire have a CON program.
Oh, maybe that's what you're going to talk about. Oh, I was just curious of the difference between states that don't have in the measure of the impact of that.
I don't have information on that. I think there are some studies out there that do discuss it. But if you're looking at those, just being mindful that there are different kinds of certificate of need programs. Some are like ours. Some are, if I understand correctly, almost more like taxi medallions. So it's not always an apples to apples comparison.
Yeah, I'm just thinking about our bills, like how do we measure the value of a CON in a larger sense? And that's what I'm interested in finding out.
Yeah. So the way that a project might fall under CON jurisdiction, there are two ways. There are cost thresholds, and then there can be also non-cost attributes to a project. So you can see here that the differential between a hospital cost threshold and a non-hospital are different. Or if the capital cost of a project exceeds just under 3.8 million for a hospital and just under 1.9 million for a non-hospital, it would fall under CON review. There's a cost threshold for single diagnostic CT scanner or a robotic arm. And so you can see the different cost thresholds there. And also we look at operating expenses for a project in the next 2 fiscal years. For a hospital, that would be $1.2 million, a little over that, in either of those years. And then for a non-hospital, the cost threshold is just over $632,000.
Can you define for us operating expense?
I think a pretty typical, the cash outlay to run a program, all aspects of the program in a year. So staffing costs, office supplies, benefits,
So 632,000. So theoretically, I'm thinking about like a one primary care provider office operating expenses for 2 years?
either year,
Either year.
one per year for either year. So, but per year, not both years.
Okay.
And then there are reasons for that a project might get reviewed that are not cost related. A change in the number of licensed beds in a healthcare facility. the offering of any home health service, although there is a moratorium on that through 2030 with some exceptions. The transfer conveyance of more than 50% ownership interest in a healthcare facility other than a hospital and nursing home, and the construction or basically any establishment of an ambulatory surgical center.
Regardless of how much it costs?
Yes.
Okay.
Then there are projects that are exempted from review, and as you mentioned, like a physician's office, healthcare, we call it a healthcare practitioner. Routine replacement of non-medical equipment like boilers, the like, and then a variety of programs that are administered by other state agencies as described here. So example of projects that we've done a CON review in the past few years have been the outpatient surgery center. Some hospitals have had emergency department renovations for major medical equipment. We've seen the robotic surgical systems, linear accelerators, and CT scanners. There have been a couple mental health or substance use disorder facilities and some EMRs. At a very high level, the process for review is that someone considering offering a healthcare service or constructing a new project of some kind would submit a letter of intent, giving the board enough information to determine whether the project falls under CON jurisdiction. The board has 30 days to issue the jurisdictional determination. And then if found to fall under jurisdiction, the prospective applicant files an application. In some cases, the project would go to hearing and the board would deliberate. And the result of that would be a statement of decision that has findings of fact and conclusions of law, and also a certificate of need. The board can grant or deny a certificate of need. If it grants it, it can be in whole or in part, and it may add conditions to have the project, make sure the project meets the criteria that it's reviewed by.
Leslie, how long is this process generally? And I come from the southern part of the state. Grace Cottage wanted their primary care, but it was painful for them. Heard about that a lot. The time frame, what was required. So what is the time frame, and do you think the process is effective as it is?
Well, the time frame can really vary, and the board has pretty specific timelines, and they can both reflect what other tasks the board as a 5-member body is engaged in at the time, and also can be the amount of time that it takes. So a complicated project may take longer to review, but it also, if the time frame comes during rate review and hospital budget season, that can extend out the review period. But the time to review the application is 90 days, but that's maybe not representative of applicant's experience, because the time tolls while the applicant has is responding to questions. So it could extend out beyond the 90 days. Then once an application closes, the application close date is an important moment. And that's when the board starts deliberating on the information it's received. If there has to be a hearing, that happens during that time. And then I believe the time threshold is 120 days from application close date to the statement of decision. There are times where there might be an extension for good cause. So I think it can be it can go fairly well. It can take longer. A lot of factors go into that. I would say a lot of projects, I've seen the simpler ones can take about 4 months, and more complicated ones can take longer, all in. And after a certificate of need is issued, it goes into the implementation phase. And I think that's something that was surprising to me when I started, is that a certificate of need is not a long-term document. It's really until the project is completely implemented, up and running, and all invoices have been paid for. And then if there are conditions, occasionally the conditions may extend the term of the certificate of need if the board is impose conditions to make sure the project is, meeting the criteria.
Can I ask, just because we had the Department of Mental Health in here yesterday. And in last year's budget, we had approved allocation for Southwestern Vermont Medical Center to essentially stand up in a youth adolescent. I can't remember the acronym. I know that Daisy probably could, but PNMI for youth with mental health challenges with some co-occurring medical. And I think she mentioned it was in the middle of the CON process. So even though the Department of Mental Health has demonstrated a need, done an RFP, been approved for funding by the legislature, that still needs to go through a CON process with the Green Mountain Care Board to determine whether it's needed?
Based on the statute, yes.
Based on the statute?
Yes.
Okay.
There are times that projects in the statute are excluded from the certificate of need process, but this one was not. So yes, it's being reviewed, and it will be in hearing next month.
Great.
So just to give you a sense of the numbers, in 2024, there were 14 jurisdictional determinations, and the board found 4 subject to review and 10 not subject to review. Here we have just a little description of what goes into a CON application, and the board received 7 CON applications in 2024.
I think Daisy has a question.
Hi.
I hope I'm not opening a can of worms, but do birth centers have to get a CON?
You are not opening a can of worms. Birth centers do have to get a CON if they meet the cost thresholds.
Okay.
That I mentioned earlier.
Leslie.
So we have a birthing center bill on our wall. How, if we're, and we also have a CON bill on our wall. So how do those two, if we pass one, even if we pass 2, what would the birthing center obligation be to the new law or the old law? How would that work?
I don't know the, I'm sorry, I
I
don't know the bills and.
No, I'm just saying there's a
Yeah.
birthing center bill. You probably don't know the CON bill. That's fine. I'm just saying there's a new CON process. That's all you need to know. And I just want to understand how the old process, and you may not know this and no one yet, will influence. Well, once we move from an old process to a new process, how does it influence legislation or, in play?
It depends on the.
Why don't we let?
Oh, good.
Thank you. Thank you.
Sam Harvey from the Office of Legislative Counsel. I think what you was about to say is what a lot of what I would say, which is it really depends what's in the bill.
Mhm.
I think you'll see when we look at the birth center bill, or when you hear about it this morning, I believe it would create an exception or an exemption from the CON process for birth centers. So the answer would be
Then we're good.
outside when applying or beginning to do construction would be excluded from the CON process. So there would be no CON.
So since the exception is in that bill, that would
Right,
be, okay.
but it depends what's in each of the bills. Generally, unless stated otherwise, all legislation takes effect prospectively. So typically it does not affect something that is already in process, but usually when you have projects already in process, we try to address that in the effective date, what the applicability will be or will not be.
Great.
The default is that perspective.
Thank you. a good thing you know
Maybe
well
we'll get to
enough.
this in later slides. I'm really curious as to sort of what decision-making goes into whether or not to approve something. Is it like what things are taken into account?
Well, the board looks at the criteria that are set out in our statute. And then in the statute, based on what I believe was like a 2017 change, there's this general directive that it should promote the public good. And the board has some criteria in its rule 4 that set out some criteria that are thought to be ways to demonstrate that something promotes the public good. So you're looking at things like, are you promoting quality? So would a project have accreditation, as we were talking about a little earlier? Is the institution that's taking it on financially capable of doing it? Will it harm other services it already provides? Will it harm other entities that currently provide that service, either financially or I think there's one criteria that's if the service is related to, the quality is related to the volume, would you be reducing the volume at another facility so that their quality would no longer be, it could be threatened. So
competition is part of the CON. I think I had mentioned earlier that I've been thinking the word competition. That's taken into account, whether or not it would financially affect another facility already provide, okay.
yes, the board would, in my experience, the board considers that anyway, and then you often find if an entity believes that it would a new project would threaten their ability to continue providing their service, they may apply to intervene as an interested party.
Yes. Go ahead.
So I have an example, but the Green Mountain Surgery that opened up in Colchester. Did they have to give a certificate of need?
They did.
So looking at the wait times that we went by before, does that take into consideration? Because if you're waiting 84 days to get an endocrinologist, and someone was to open up an endocrinology practice, I mean, would you look at the two different things? Like one, someone else is already providing it, and two, you have to wait 84 days to.
Well, yes, I mean, it's in the name certificate of need. So is there a need? That is one of the very first things that gets looked at is, is there a need for the project?
Okay. I think you answered my question.
So in 2024, the board approved 4 CONs with a total value of about $159.5 million. They were the UVMMC's purchase of the Fanny Allen campus, the UVMMC Outpatient Surgery Center. Mount Escutney had an electronic health record replacement, and CVMC replaced a linear exposure.
When Central Vermont, I know I keep harping back on these 8 inpatient beds. When Central Vermont Medical Center opened those beds, did they have to go through a CON process?
I don't know. That would be before my time. And I haven't seen a record of it, which means nothing. It means I didn't open that file in the computer.
Oh, can I? Or I almost said Representative Blanford.
No, I was just saying, council has.
Oh, yes.
Again, Mike Barber, General Counsel for the board. I just wanted to highlight, I don't know if they have to go through CON to get those beds initially, but
I don't think they did.
sometimes the certificates of need expire after the reporting is done and the project's implemented, the CON expires and any conditions that were in that kind of go away. So there's nothing left. If they did have to go through CON, there's nothing kind of left for the board to do.
What is the expiration date on a CON?
It varies.
Does it vary?
It varies, like Ms. Belva was talking about, depending on how long the applicant needs to do the project, and then if the board has imposed certain conditions that it wants to see kind of extended out, like over a certain amount of time, it just varies.
I guess I'm thinking about sort of a reverse CON, which is if you've asked for a CON and you've demonstrated there's a need, can you just shut it down without the authority of the board approval to say, go ahead and shut it down?
Right, so we have heard, people talking about that, so I have addressed it here. Currently, our CON statute does not provide for that kind of review. And so knowing that you're trying to look at, what to do, what makes sense, we thought it would be helpful to give you a summary of what our peer states in New England have done. And this information was collected by talking to our, fellow regulators in the other states. And so for hospital construction and renovation projects, Connecticut, so Connecticut does not actually review them, but then they kind of review everything else, if I understood the description of their program correctly. You see the thresholds in Rhode Island is 7.3 million, Maine is 13.7 million, and Massachusetts is 26.1 million. And in comparison, ours is Vermont, I had it in my notes. Ours is about 3. Yeah, ours is lower. I apologize. I have little notes that I did not bring with me. So Vermont is lower than Rhode Island, so it is the lowest in New England. For a single piece of major medical equipment, Massachusetts is the lowest at 1.4 million. And actually for a non-healthcare facility, it's 387,000 for a piece of major medical equipment, where Rhode Island is at 3.2 million and Maine is at 4.4 million. And Connecticut apparently reviews all major medical equipment regardless of cost. For the birthing centers, because we knew that was being discussed in Massachusetts, the independent birthing centers are not reviewed unless the cost exceeds $42 million, but hospital affiliated birthing centers are always reviewed. Maine does not review, and Connecticut and Rhode Island don't review from a CON perspective, but there are licensing measures in place.
A licensing procedure would just be sort of, are they meeting the standards of care and?
Yeah, the public health criteria. For one-to-one routine replacement of major medical equipment, there is no review in Massachusetts, Connecticut, or Maine for that, but Rhode Island still does review. And termination of services and programs, Connecticut reviews if it is a termination of inpatient or outpatient services provided by a hospital or an ASC. Massachusetts and Maine don't review from a CON perspective, but the licensing authorities would review. And Rhode Island reviews only when it's a hospital terminating either primary care or emergency services.
What's D? Sorry.
Oh,
DON. No.
Determination of need.
Thank
Just
you.
a different acronym.
Mhm.
And for material change thresholds, so in Vermont, the board has set material change at in its rule in Rule 4 at 10%, or if the project change in scope is sufficient to make it essentially a new healthcare project.
I'm sorry, can you explain what material change?
We've had several recently with the inflation and construction costs. So a project comes in and the healthcare provider says, oh, it's going to cost $1 million. If it ends up costing more, there's cost overruns or just whatever, then Vermont sets it at a 10% threshold, or if there's a change in the kind of service that it's going to be enough to make it a new healthcare project under those original thresholds we talked about. And so in Rhode Island and Massachusetts, they also have a 10% threshold. Maine doesn't have a set amount that says if it's increases by a significant amount, which is defined on a case-by-case basis. And in Connecticut, material changes are reviewed by the Office of the Attorney General. So that's the end of my presentation. Do you have any other questions?
Yeah, it looks like we have a couple. Woody?
Yes, in our bill that's on the wall there, page 96, for a healthcare project, it currently states that if the costs exceed $10 million, that we have to get a seal. Is that high enough,
Is that high enough?
or should it be more?
Should it be more? I don't have a personal position on it, but I know that we've discussed it with board members, and there was a general appetite for, I believe, around a $10 million cost threshold.
Okay. That really doesn't answer the question, but that's fine. I mean, looking at, the 4 items that you had up there, they're much greater than $10 million. And with inflation issues, $10 million doesn't go as far as it used to.
No. One thing the board started doing a few years ago, it's allowed in the statute, is to actually increase the cost thresholds based on inflation. So that has been, but the numbers say that that's what inflation increases are. That may not feel sufficient.
The bill on our wall, 96. I'm looking at the operating expenses, and that just seems like a very low threshold to me.
We see particularly in hospitals, but I don't think you can turn around on the street and have operating expenses lower than that threshold. We see a lot.
You can have more than 3 employees and be under that threshold.
No.
So in the bill, H96, and I'm not finding the threshold right now. Is that something that you all have discussed, and does that seem like a reasonable number? I think it's,
Sure.
yes, of course.
Ellen Foster from the board. I think it would be best if we came in and specifically
Okay.
spoke to that bill, if it's
Okay.
okay. I would say that one complication, so, we have staff and we have 5 board members, and when we speak, are we speaking for us or 5 people, like for who? I will say that there is support at the Green Mountain Care Board to increase those thresholds significantly. I personally would say higher than 10 million, but I think the consensus position, if you will, of the board is that 10 million is probably a good number.
How many people within Green Mountain Care Board actually work on the CON process? What resources are you currently utilizing for this position?
So it depends, again, on the board, it's, the UVM Outpatient Surgical Center, incredible, immense amounts of time by all board members to dig into all kinds of data, issues. Then we also have the staff who will request information, do RFIs, follow up, read everything, educate the board. That's predominantly 1 or 2 people, and then you have all the board members. So I would say 2 or 3 staffers, but they're also doing other things with valuable health rights. rate review opinions, hospital budget opinions, records requests. So, I would say our staff is 2 on rate review. Is that fair?
Yep.
Two people plus the board.
So increasing the thresholds may alleviate some of the burden in it's staff time that could be utilized for other
For sure.
resources.
It depends on the year and what the submissions are that year. Like 1 year, if you don't have a UVM outpatient surgical center, like it might not be that huge of a burden, but with years when you have that kind of request, it is significant staff time. And I'd also say it would reduce the burden on the entities, as we mentioned, Rebound Surgery Center. That was a very, very expensive and difficult process for the regulated entity as well. And for hospitals and lawyers and all consultants, there's a lot of expense that goes into this.
I'm sorry, I'm not seeing if anyone else has questions. Is there a fee for submitting? Okay,
Yes.
It is earlier in the slides. It's on the page that says application.
okay. And if you go through the entire CON process and then it's not, it doesn't come to fruition, is there a fine? It's just essentially the fee that we charged originally.
Yes, I mean, when you say come to fruition, saying,
Well,
somebody applies for a CON, they receive the CON, but then they don't make the project.
yes, I'm thinking about,
That's one of the few like hard and fast deadlines we have after the CON is granted. And I believe that an CON holder has 5 years to complete a project. If it isn't completed, then they lose that CON. It's not, I'm saying that from memory. It's not a statute I've ever had to actually rely on.
thank you. Any other questions? All right.
Thank you. And some of us have meetings.
Yes, and I made everyone go over,
We all made everyone
go over yesterday, and you're right, some of us do have meetings. Can we reschedule the rest
Yeah, of
at
course.
another time? And I apologize that we weren't able to. I was thinking 3 hours was long, but it's not nearly enough.
It flew by as far as I could.
It did blow by.
Interesting and
It did blow by. Thank you for coming in today. I think we're gonna see back some of you tomorrow afternoon.
It'll be member Holmes and staff member Hillary. That will be here tomorrow.
And personally, I would like to thank you for your candor
Yes.
and transparency.
Thank you. Thank you for the questions and for inviting us into the staff for working on this deck. Very thorough and in short time, so I appreciate the staff doing the work.
Yeah. And we'll get the rest in here